So, good afternoon, ladies and gentlemen. In the name of God, most gracious, most merciful, thank you so much for joining us today. My name is Obaida from Glaucoma Division. I'm going to be your session moderator for the next 1 hour or so. So, this session was basically scheduled to be presented by visiting professor, Dr. Jose Bilda from Spain. Unfortunately, due to emergency family issue, he couldn't make it to Riyadh. So in a matter of like 2 days, uh, our hero, Dr. Konrad Schargel, the division chair, he managed to replace this session with another session. It will be presented by our heroes as well from the division. So thank you so much, Dr. Konrad, and thanks to all the speakers. So our session title today is going to be When the Space Matters. We'll be starting with a small presentation on the essentials of gonioscopy. It's going to be presented by Dr. Dania Bamefleh. She's a consultant at Glaucoma Division in King Khalid Eye Specialist Hospital. Dania is going to tell us what's the importance of learning a good gonioscopy and is the OCT or UBM, please, Dania, answer this question, is going to replace gonioscopy or not? Thank you. Please.
Assalamu alaikum, everyone. Good afternoon. So gladly, I'll be starting upon an overview of gonioscopy, the essentials and the basics. I have no financial interest in this talk. So the history of gonioscopy, it was first discovered by the Greek ophthalmologist, Dr. Alexis Trantis, that discovered it incidentally while indenting the sclera of a patient that was suffering of keratoglobus, and he was able to see the landmarks of the angle of the eye. And as you can see here in this photo, the photo is here is a keratoglobus in a child pediatric age group, where you can see all the structures of the angles are visible and clear without even moving the eye. And this picture was actually awarded in the RSOS back in 2019 as the best photo of that year. And the credits goes to this team, Dr. Sisma, Dr. Kharbouch, and Dr. Schargel. So first of all, gonioscopy, it's the area or the skill that we gain to achieve a good assessment and evaluation of the angle structure and the anterior chamber depth. So it will answer us diagnostically and prognosis-wise and therapeutic-wise. So all of these will be answered by the simple gonioscopy procedure. But why are we doing the gonioscopy to begin with? So first of all, it's an important part of any comprehensive eye evaluation. And its omission from the evaluation can lead to misdiagnosis and poor judgment, and should be done initially in all glaucoma patients and all glaucoma suspects. Should be repeated periodically, especially in those eyes with narrow or closed angle form, and has a role in the intra-op intervention for micro implants, as we will see later. So for the diagnostic part, it will definitely answer the status of the angle. Is it open? Is it closed? It will identify secondary angle pathologies like pseudoexfoliation, pigment dispersion, neovascular glaucoma. It would confirm the positioning of a tube. Like in this photo, as you can see, this is a gonioscope photo, and it will show you the position of the tube, if it's too anterior or posterior. It would also answer your surgical PI question, like, does the patient have a wide enough surgical PI? Sometimes we're not able to see it with the normal slit lamp evaluation alone without the aid of a gonioscope. Is the internal os of a pre-existing trab working, functioning well or not? And as a prognosis factor, it can be a prognostic factor for cases that are either synically closed or positionally closed. So you can identify this by simple dynamic test at the clinic with the aid of the lens, gonio lens, where you can see the angle now is open after compressing the central part of the cornea by the gonio lens. So for the therapeutic part, yes, it can be used therapeutically, like in the surgical view of sitting of cataract at the same time. You can do micro-invasive procedures, and we have a lot of those that emerging now in the market. For mild cases, it would be very good option, and sometimes with people with compromised conjunctival surface. Like the first one is an example of the new generation of eye stent being injected. And the second photo, the one below, is an example of a Cahook dual blade, with which the surgeon is doing a goniotomy ab interno. So what are we looking for, or the structures that we are looking for in the gonioscopy? We're first of all trying to recognize the angle landmarks. We are evaluating the level of iris insertion. We are identifying the profile of the peripheral iris and the shape, estimating the angle depth of that eye, and we are studying the degree of trabecular meshwork pigmentation, the presence of any iridotrabecular apposition or the synovial closure. So now we'll move on to the methods. We have the direct visualization, which as we saw in the event of surgical sitting, or for diagnostic purposes in OR. And we have the indirect that's easily done in the setting of a clinic outpatient services. So the direct gonioscopy, that the things that are beneficial or the advantages, that it's straight on the view. Whatever you're seeing is the proper site, and it has a panoramic view, and you can easily move it and navigate it. The disadvantage is that it's inconvenient to put the patient in a supine position, and it requires like some tools to be there. It's not as quick as the indirect for sure. And we have nowadays the Gonio Ready system. That is a system that we usually inserted, integrated with the microscope. So in order for us to use, or for the surgeon to use bimanual, um, like procedure-wise and so on, and he has both hands are free instead of holding the lens with his other non-dominant hand. So the indirect can be either as a suction type or a non-suction, depending on types of lenses. And these are examples of types of lenses. We have the 3-mirror gonio lens, and this is an example of what you see in a Goldman 3-mirror sitting. And we focus our attention on the D-shaped lens, and the others would be for the other peripheral parts of the retina. The 4-mirror gonio lens, which is very easy and convenient, and this procedure will not take more than 1 minute at the clinic. And we have the latest advance, which is the 6-mirror gonio lens, and the beauty of it that you don't have to move around much as with the other previous generations. So what are the indications of gonioscopy? Observed narrow angle is a must. History of an angle closure attack is a must too. History or an evidence of a previous trauma or a foreign body inside the eye. Active or past inflammation in the anterior chamber. Evidence of a new plastic activity or a suspicion of that. And the possibility of new vascularization. When should we not do gonioscopy? Are there scenarios where we would avoid it? Yes, there are. Like in the event of globe compromisation, or like fear of rupture globe, you shouldn't apply further pressure on the eye. Ocular surface infection, a recent infection like a herpes simplex or epidemic keratoconjunctivitis, or in a case of a freshly blood or a fresh hyphema inside the eye. So what are you looking for? Whatever you are seeing, it will not be the best judgment because of the presence of the fresh hyphema. And in the setting of an epithelial basement membrane dystrophy, meaning that this will leave the eye vulnerable for epithelial defect and so on. So this is an example of a normal angle structure where you can see all the structures pronounced, and we'll go through them. The first structure is the iris. So what are we looking for in the iris? In myope patients, you can see the concavity of the iris. In hyperopes, we see a convex like the one in the upper slide. And in cases of pupillary block, you will see an abnormal extra convexity of the pupil and the stuck of a stagnant pupil. Abnormal concavity, which is very pronounced, or the hallmark of the pigment dispersion syndrome. And you can see also a plateau iris with a double hump, like the one at the inferior border. The ciliary body band, so we look also for the ciliary body structure. We look for the width of it, the presence or absence of a cyclodialysis. Next, we have the scleral spur. So usually we see if it's obscured by iris prosthesis, iris bombae, peripheral anterior synechia, pigments, all of those will be obscured by the scleral spur in those scenarios. Trabecular meshwork pigmentation, and also it will also help us to identify the Schlemm and the Schwalbe's canal. The Schwalbe's line, or the Schwalbe's line, sometimes it's hyperpigmented, like in cases of pigment dispersion or in cases of pseudo-exfoliation glaucoma. And then we have the systems of grading. We have either the Schiess system, we have the Schaffer, the Spaeth, and the Van Herrick, and all of those are different modalities to evaluate. At least just stick to one of it to diagnose one of the three systems. And then the clinical evaluation would be by the Van Herrick system. The first one, the Schiess system, it's usually the most posterior structure that's visible, would be like labeled as number one, and the opposite with the Schaffer system. The Spaeth, usually it depends on a 3D structure of the angle level insertion of the iris and also the level of pigmentation. The Van Herrick is the one that we widely use. And how do we use the Van Herrick? We shine the light beam at an area that is next to the limbus, and it will evaluate the AC depth with a narrow slit beam. The first line will be falling on the cornea, and the second will be falling on the iris plane, and usually at an angle of a 60 degree to evaluate it accordingly. And these are the different stages of the Van Herrick. So if it's grade 1, it would be like less than 1/4 of the corneal diameter. Grade 2 would be almost equal to that, to 1/4. Half would be the grade 3, and grade 4 for more than one or more of the corneal diameter. Now, this is a very nice algorithmic pattern if you can take a photo of it. So in each patient, all structures are visible and in the proper, correct anatomy. Then if it's yes, then look for the trabecular pigments. Is it normal? Then this is most likely a primary open angle glaucoma. If it's abnormal trabecular meshwork pigmentation, look for the Schwalbe's line. Is it heterogeneous hyperpigmented? Usually this goes with the pseudo-exfoliation. If it's homogeneously pigmented or heavily pigmented all over, then this goes usually with the pigment dispersion. If to begin with the structures of the angles are not in their normal configuration, if the answer is no, then it would be one of those three. Is it poor differentiation of anterior iris insertion? This is most likely goes with a congenital glaucoma or a juvenile entity. If the angle recession, iris disinsertion, ciliary body cleft, this most likely would be post-trauma. And last but not least, are there any synechia? Or are there any blood vessels? So this is either uveitic, neovascular, or ICE. Thank you so much.
Thank you so much, Dr. Dania. Excellent presentation. And you didn't answer the question, Dania. So you think OCT or UBM can replace the importance of gonioscopy? Okay, so here we would like to stress that gonioscopy is very important part of the ophthalmic examination that should be learned and mastered by all the ophthalmology practitioners, not only by glaucoma specialists, because you need to know what's the situation of the angle. You might need it even as an anterior segment or cornea specialist. to put some of the simple mix. So it's very important part of the ophthalmic examination. I like to refer all the junior trainee to gonioscopy.org website, which was funded and started by Dr. Wallace Alward. It's very important, very nice website that you can check always nice videos of gonioscopy, and you see how to go for different pathologies. Thank you again, Dr. Dania. The next will be how to approach patient with narrow angles in a practical guide by Dr. Ibrahim Al-Obaida, a consultant at Glaucoma Division, King Khalid Eye Specialist Hospital. Please, this is very important topic. Go
Thank
ahead.
you very much,
Thank
Dr.
you so
Ahoud.
much.
Assalamu alaikum. Good afternoon, everyone. Today I'm going to try my best to get you through how we should approach any patient with narrow angle and how we can treat them, and what to look at when you diagnose patient with narrow angle, and what you can offer for your patient with a narrow angle. To start with, this is my outlines of the lecture. I will go quickly on the pathogenesis, then I will talk about management. Later on, we'll conclude with one case and see how would you manage that case. As I know, I always reinforce or try my best to have the definition in a right position. So I always encourage, if you're labeling any patient, to make sure that you labeled as what it is. So if we'll spend a little time here to make sure that we have the same language when we talk about any patient with narrow angle. So if you have a patient with a glaucoma suspect, you would expect that iridotrabecular contact will be more than 180 degree with normal IOP and absent of any synechia with no optic neuropathy. While if you have back, or what we call it primary angle closure, there will be a contact, and also there will be either normal IOP or PAS, or will be elevated IOP with BAS or without BAS. So in order to call the patient as back, you should have one of the two, either elevated IOP or present of synechia with no optic disc damage. In a primary angle closure, obviously you will have elevated IOP with the present of BAS and also optic disc damage. An acute attack of primary angle where IOP will be very high, and you might have BAS, you might not having synechia, and also you might not have optic disc damage or might have optic disc damage. So an acute presentation, patient might present as acute on top of chronic angle closure, or he might be present as a primary with acute attack only of angle closure. So what do you expect to see, or what do you expect the change in a patient with angle closure? Usually those patients have shallow anterior chamber, obviously, and also they have thick iris and ciliary body, and small eye, what we have it more hyperopic eye. So the role of the lens in a primary angle closure patient is very crucial and very important to understand it, because the treatment will be guided towards that. The lens itself, it might be swelling, and this causing narrowing of the angle and closing the angle eventually. And also, not only the size of the lens, the position of the lens itself. It might be shifted up and shallowing the anterior chamber more and more for you. And also some studies, they found out that most of the patient, or 60% of the patient, present with anterior displacement of the lens position comparing to normal lens position. So we'll go through the management now. First of all, we'll talk about how would you approach patient with a glaucoma suspect, what you should offer and what you should tell the patient. So laser peripheral iridotomy is the first line treatment in a primary angle closure and a primary angle closure glaucoma. Also, it is one of the most commonly prophylactic laser treatment we do for patient with angle closure suspect. So we're doing it as a prophylactic, not as a treatment. So we prevent what we call attack of angle closure, or converting to angle closure. There is no clear guideline when to do it and how to do it exactly in the time. should we change our approach? This question, I think it's answered very well by ZAP study when they did randomize the patient either for laser peripheral iridotomy or just observation for a patient with a primary angle closure suspect. And their endpoint or primary outcome that they measure after 72 months is either the patient is converted to back, which will have high IOP or present of PAS, or they had an acute attack of glaucoma. So they measure how many patients that they convert from suspect to back or angle closure or acute angle closure. At the end, what they found, they studied or they did around 889 with a laser, and they have 80 same number for control group. Only 19 patient with a treated group or treated arm, they reached to the primary or end result, while in 36 in a patient where their observation only, they didn't do anything for them. It is significant more with those patients, but what I want you to see is that most of the patients, they develop BAS rather than having high IOP. Only 5 patients with a control group, they develop high IOP or increase in intraocular pressure, while 3 in the treatment group. Also, the present of acute attack were more with the control group there, where they didn't do anything. They end up that they calculate how much the risk for the patient to develop acute angle closure or to convert from suspect to back. It is around 4.1 in every 1,000 patient with a laser, and almost 8 in a patient without laser. So almost half of the patients, double the patient will go for attack or will convert if they're suspect without treatment. So in their study, they conclude that massive BI, it is not recommended as per their papers, but they recommend if you're going to do laser, you have such scenarios where the patient either symptomatic or having family history or having a narrow angle with a pass, they convert, or you anticipate a lot of dilation, so you might aggravate or might push the patient to have acute attack. And those recommendation or those finding is related to their population, to their paper, and to their outcome. So till now, I believe that laser peripheral iridotomy is always recommended a patient with a glaucoma suspect, primary angle glaucoma suspect, to prevent an attack, even if it is very small chance that he will go. But I always make sure that I tell the patient that this does not mean that it prevents you from glaucoma. You might still have a high risk to develop glaucoma, so you should always follow up and not lose your follow-up just because you did the laser. Because some of the patients feel that that I did the laser, that's it, I don't need to do anything else, I don't need even to follow up. So stressing in that is a very important approach. Second is how we handle patient with angle closure back or primary angle closure glaucoma. So again, is the laser peripheral iridotomy is the option? Do we have other option for those type of patients? Is there any way to treat those patients, or we can offer for them another solution? Also, another clinical trial, which is EAGLE clinical trial, where they randomize the patient with a primary angle closure and primary or newly diagnosed primary angle closure glaucoma, either for clear lens extraction versus peripheral iridotomy. It is multi-centered randomized clinical trial. The patient were selected, they need to be phakic, obviously, and they're above 50, so they don't lose any accommodation, and also newly diagnosed with a primary angle closure glaucoma or primary angle closure with high IOP. They exclude if the patient have cataract, because it will be obvious that you will remove the cataract, and if they're advanced glaucoma or severe glaucoma damaged. What they end up as a result, most important thing, the group were receiving lens extraction, they have less needed for treatment. So if you remove the lens earlier, it will help the patient to control their pressure, but anyhow, either medication or surgically, and even fewer medication was used in a patient with a clear lens extraction. If you see, there were 208 patients with clear lens extraction, uh, and also 211 in a laser peripheral iridotomy patient. Very obvious that additional glaucoma surgery, it is less commonly in a patient with clear lens, while the patient with peripheral iridotomy, they needed more intervention, and mostly is cataract extraction later on in their life. So they conclude that lens extraction, it is an option for patient with angle closure back or primary angle closure glaucoma. So it is an offer that you might give to your patient if he develop a high IOP related to angle closure or having a glaucoma, early glaucoma. Another study, which is very interesting, Korean study, what they did, that they treat or they look for the patient that had an attack in one eye, angle closure, and they did cataract for them, and they follow the other eye with early cataract extraction, and they compare between eye how much the rays of IOP will happen in both eyes, or who will have more glaucoma or have attack of a glaucoma or will develop a glaucoma. So their aim, they want to compare, shall we wait till we have an attack or removing it early will help to control the pressure? And obviously what they found that there is a significant higher IOP raising in a patient where they have an attack in that eye and also remove the lens, comparing to if you remove the lens in the other eye where there were no attack of angle closure before. This study or this paper, what they try to find who will benefit from lens extraction. Is the only early diagnosed patient or early glaucoma patient that will benefit, or the advanced or the higher patient complex will be benefit also? What they found that the higher benefit or the efficient of lens extraction will be in a patient with a higher IOP presentation, and also if they have a BAS or they have higher medication use before the surgery. So this gives us a hint that even if it is if the patient present late or having multiple medication or he develop a BAS, still there is a chance or there is a room for removing the lens and get rid of the attack of the narrowing of the angle itself. Now we'll go to the primary angle closure. Glaucoma patient, where you have it patient with advanced or becoming a glaucoma patient on medication, and you need to have an intervention. Trabeculectomy is the gold standing procedure for glaucoma. I would say for both. Maybe Dr. Schargel will not agree with me. For open and closed angle, it is a gold standing that we need to do it for a patient with uncontrolled pressure. But what it is carry with in a patient with angle closure, why we're hesitant or we try our best to avoid trabeculectomy, especially in narrow patient or an angle closure patient. They have the higher risk to develop especially aqueous misdirection and other complication. So those type of patients, they're in high risk, so you don't want to disturb the anterior chamber with the shallowing that you have to end up having a complication. Here will be the second question. Shall we go with a cataract or without cataract? This topic have been studied a lot, and they tried to look at what is the benefit or what is the chance of lowering the success rate if you do it with a cataract itself or you do trabeculectomy alone. One of the study where they observe the patient were doing combined surgery versus patient doing trab alone. What they found that the end result, as you see here, the IOP after 36 months, the IOP were similar between two groups, qualified success were a little more with trabeculectomy alone patient, and also for complete success, almost similar between two groups. So they conclude that both trabeculectomy alone and trabeculectomy with a phaco is beneficial to lower the IOP. Also, you will get the benefit that the patient will get less surgical intervention later on if you remove the lens at the same time. So this will help the patient to go without having later on cataract extraction. So in general, if the patient has cataract and he's angle closure and you need to do trabeculectomy, it's better to go in both with the cataract extraction rather than stage it and later on doing the cataract surgery. What about gonioscopy? Is it working? Is it effective? We all know that Synekia is developed in a primary angle closure, but what if we release that Synekia? Is the angles will work again? It's very convergent. Still, the literature is not very clear about is this benefit or not for primary angle closure patient, because it is not only about the position of the iris itself, rather than the trabecular meshwork itself is affected anatomically. So one of the studies that they did a randomized clinical trial where they compare between doing phaco alone versus phaco with gonioscopy. And what they end up, they have similar baseline. What they end up that qualified and complete success are equal between two groups. So there is no additive point to do gonioscopy with a patient with angle closure and also have a synekia. Well, what about ECB? One of the studies done here in our hospital in Kekish, Dr. Morales and his group, they looked to the patient who did phaco plus ECB, an advanced glaucoma patient, and they looked for the 1-year outcomes. From those patients, they have 44 patients with angle closure. 6 of them, they have complete success, and 18 patient from the 45 patient, they have what we call qualified success. So it is working even in advanced glaucoma patient. It might be an option that you offer to the patient. Another randomized clinical trial done to compare between phaco plus phaco ACB versus phaco trap, and they want to see how is the effect of phaco ACB in a patient versus phaco trap. They have a similar baseline IOP preoperatively. What I want to show you is the result. As you see here, this is the table of the IOP during the follow-up, comparing between phaco ECB and phaco trabeculectomy. Obviously, day 1, you will have lower IOP in a phaco trabeculectomy patient, but with the time, this IOP will raise till you reach to the end follow-up or the last follow-up where both IOP are comparable between two groups. So this gives us a hint that phaco ECB, it's working versus phaco trap. And other thing that you might consider for your patient is the rate of complication. In a patient with a phaco trap, obviously they have a higher chance to have a complication, and those complication is a serious complication that you want to avoid for your patient with high risk of complication. And not only the rate of the complication, if you see here, 8 patients from phaco ECB, they end up having a complication, but 4 of them needed an intervention, while 13 patients from the phaco trap, they had a complication. Around 10 of them, they end up having an intervention, which is a good number of patients with a complication. They end up having an intervention for that complication. So what they conclude that it is effective, the phaco trabeculectomy versus phaco ECB, but still the phaco trabeculectomy having a higher chance to develop complication and intervention after the complication. inshallah, soon we will have our phaco ECB versus phaco alone trial, where we did a comparison between phaco alone versus phaco ECB in a primary angle closure patient. We want to see how is the ECB is effective in treating patient with a phaco phaco alone or ECB. Is it an additive, or we just phaco itself? It is the one it's working for those patients. So I will end up with this case, one of the cases that I had in the clinic. This is a 54 years old male present with a primary angle closure in the left eye. Obviously, his vision is 20/20. His IUB is 20. Our concern is the left eye. He is in two medication or three medication. He has early cataract changes with healthy disc. The question where what we should do the next, what we should offer the patient the next. So what do you think? Are you going to do just peripheral iridotomy? Patient was not having any peripheral iridotomy. Would you go for cataract surgery strictly directly, or would you go for combined doing cataract and plus glaucoma, or you will just observe the patient and follow him up as long as he is controlled in this medication? It is not very clear. Some they will agree that they might go for peripheral iridotomy for all the patients, and they will just offer PI and observe them and follow them up. Some they might go and say, listen, this is a cataract. I would go and just remove the cataract alone. It might help the patient because if you see his vision is 20/20. So what I did for him is phaco ACB. Gonio, from it is a positional angle closure. It is a positional, and if you see OCT, anterior segment OCT, you could see there is no synechially in the gonio, but the angle is narrow and it is a positional. It is will open with removing with the pressure. So I elect to go for phaco ECB. Patient end up having 20/20 with normal IUB and also without any medication. So this is my algorithm that I use in the clinic, how to approach patient with narrow angle. Always remember one thing. If you have a patient with narrow angle and cataract, always try to remove the cataract as soon as you can. The question, shall you do BI before or not? This depends on you, depends on how long you will let the patient wait. If you think the patient will wait for longer period, BI is a must. You don't leave the patient with the BI. If you don't have cataract, this will be a bigger dilemma. Shall I go and just do clear lens extraction? Literature shows that they might get benefit. Still, it's not clear who is gonna get the benefit, but it is a major surgery. So you can discuss with your patient if he is willing and he is passing 50 years old to go for cataract extraction. This will be a great option for them. If you have a patient with glaucoma changes, always remember trabeculectomy is an surgical option for a patient with advanced glaucoma angle closure. If you have a cataract with it, you should go and do both combined surgery. Otherwise, trabeculectomy alone works great on those type of patients. Thank you very much.
Thank you so much, Dr. Ibrahim. Very excellent and useful approach to one of the most important topics in glaucoma. Please stay on the stage. So actually, I couldn't stop you. You took more than the time allocated for you, but it's very important and very valuable information that Dr. Ibrahim showed us. I have two questions for you, Ibrahim, regarding the EAGLE study. Now, in case of, for those who are having their lens removed and the disc is fine, no pass, everything is okay, pressure is controlled after the cataract surgery. You said that the probability of having, glaucoma or having high IOP is very low. So for how long would you follow up those patients? 1 year, 2 years? Is there any chance that they can develop high IOP or any glaucoma signs in future?
Thank you very much. Very good, great question. Again, for me, always, if your patient have high IOP, he should follow you all the time. Yani he should have and follow with you, even if you treat him, even if you do laser peripheral iridotomy. How long? I don't have an exact number, but the patient should have a regular follow-up, and it's not solving a problem. We didn't solve the glaucoma on him. We tried to manage him surgically, but he might have still, again, some of the patients, even with the BI, even if they did the BI and the IUB is controlled and you're deepening the AC, still they will go for glaucoma. So I believe there is some anatomically changes in the trabecular meshwork proceeding by narrowing of the angle, but still there are a higher risk to develop glaucoma. So I never ever discharge a patient as he is stable and he does not need to do anything, especially if they have any attack of high IUB, elevated intraocular pressure.
Yeah.
That means the system is not working probably. So he needs to be followed up all the time.
Uh, Professor Saleh, Dr. Ibrahim, Dr. Konrad, you all agree? So, like, for life, follow up for life?
Yeah. Okay. So according to a long time ago recommendation by the American Academy, any person above the age of 40 with any risk factor or family history of glaucoma, they have to examine their eyes once a year. If you don't have a family history, no intraocular surgery, no any risk factor like thin cornea or abnormal disc, you can follow up every 2 years for glaucoma examination. This is what they recommend for any national screening program.
But probably with the high prevalence of glaucoma in our country, it's worth it that we need an eye for those patients maybe for a longer time. Dr. Conrad, you want to comment?
I absolutely agree with what you were saying and the question. But I have to try to make it controversial. As a hospital that manage a lot of patients, we should be careful the way we plan to make our planification. One thing is great. I will try to see all my patients. And I use that expression very often. I never discharge any glaucoma patient. I don't feel safe. I wouldn't do with my parents.
Is Dr. DB around from the eligibility? He's not.
So
Okay, feel free. Feel free.
But I think that these patients that we do the phaco, you remove one of the most important pathogenic origin of that glaucoma, can't be seen with longer period of follow-up. You don't need to give appointment every 2 months.
Yes, thank you.
Dr. Bro.
Just the other thing that you talked about him about my point.
Yeah.
Mashallah.
Mashallah,
I'm from the school that I hate, and in fact, I list in law of very poor visual protection. I'm not sure that, although he showed that the difference between the rate of complication and severity of complication between traffic or PCB, probably if you didn't do the PCB, even take alone, probably you will have the same result. So I wouldn't go for ECB at all or any type of destructive procedure. I live whether ECB or CBC or whatever, unless really the visual, unless I really exhausted all the well-known and predicted surgical procedures, trabeculectomy, whatever. But destructive procedure, tumor is the last thing, last resort for me. To go for a healthy eye and so on, do because of the pressure is with 20s or 30, even when the disc is healthy, and go and do such destructive procedure, and I cannot accept it at all. All the people that they are practicing such a thing.
I agree if it is aimed to for destructive. You allow me. Very great input. I agree if it is for destructive, but one of the things that ECB do, it's changing an anatomy. So it is one of the, even they call it endocycloplasty, or it's when you shrink the ciliary body, it will pull the trabecular meshwork. this will allow to open the trabecular meshwork. So there is some benefit from anatomically change rather than just, I don't believe that ablation of the ciliary body per se will lower the IOP as it is, as decreasing the production of aqueous. It might have some role, but the main rule is that to shrink it so you can pull the ciliary body back to either because of it is more anteriorly in a patient with plateau iris, for example, or in a patient with angle closure. So there is some anatomical change that you might expect with a patient with ACB. And also that's why even if you're planning to do phaco with the ECB, you should consider the refractive error that you might get. So the lens position, it might change. And this is what also we're trying to look at in our trial, that we want to see how predictable is the lens, because the position will be changed as you're pulling the ciliary body, and this will pull back the lens position. So I totally agree. Cyclodestructive per se, it is not an option if in a healthy eye.
Okay, now back to Eagle study. My second question, Ibrahim, is, you know that the study was conducted and designed on patients more than 50 or 60
True.
years of age.
True.
Now, if you have a young patient with clear lens, angle closure, would you apply Eagle study?
Dr. Konrad,
this is very controversial question.
Below.
Young, clear lens.
Good question.
In my experience, it is very young, one, and we have a few cases of that. I would approach removing the lens alone, even glaucoma, angle closure glaucoma, in very young patients. I will, from the experience that, I think it's
we need everyone to hear you, Prof.
Okay,
we need
okay.
everyone to hear
okay.
you, please. Thank you.
Probably 4 or 5 cases you cannot, conclude something rigid in that area. But when you see the agony that we are passing through with these patient, young people, and I approached my colleagues in anterior segment and core and the retina about how to approach this patient. Shallow chamber, history of aqueous misdirection after trabeculectomy in one eye. So what I reached that, I believe, yes, to remove the lens, clear lens, even without doing glaucoma surgery as a first procedure, this may be the answer. So if later on needed to go for, or pressure is not controlled on one medication, as my school says, that need more than one medication, I will go for trabeculectomy, for example. But I will agree that I will go ahead and do clear lens extraction in a young patient, as we do in spherophakia and the microspherophakia and so on. So I will not leave a patient just for trabeculectomy only to control the pressure in such patients.
And what type of IOL would you put in
Sorry?
that? What type of IOL would you put for that?
Well, it depends. Nowadays, probably I will go for enhanced or
EDOF.
no, multi-EDOF, probably better than multifocal. But multifocal, I don't have something rigid to depend on.
Yeah.
But EDOF is the midway between them. I will go for EDOF.
Yeah. Dr. Ibrahim?
Just
Thank you, Prof.
thank you, Dr. Ibrahim, for the nice presentation. Just going to the previous discussion regarding what to do in angle closure, I think it's not a bad idea to do PI in all patients, even if they have cataract and you are planning for cataract, because you don't know, the surgery may not happen. I mean, the case can be canceled due to medical reasons, COVID, something that happens, and the patient will disappear for a long time. So a simple procedure can prevent. And even sometimes if you dilate the patient, we depend that we will do cataract. But if the patient surgery is canceled on table for any reason, then he may get into angle closure. Okay. So it's a good idea to do PI. In case of clear lens or visually not significant, sometimes it's just mild nuclear sclerosis and things are fine. If we do the PI and the pressure is fine without multiple medications, maybe it's also fine to wait for some time until this cataract is visually significant. Visually significant means if the patient is disturbed either day or night, but not just because I remember Dr. Karim Tami, he said, you don't climb a mountain because it's there. Not to. So you don't do cataract because it's there. This is what, he always says. The other thing is as Dr. Saleh mentioned, if the disc is healthy, probably it's fine to proceed with just phaco rather than
doing it as
yes.
But don't you agree, Dr. Ibrahim, that if you have cataract with a narrow angle, then just taking out the lens will can solve like 90% of the
definitely.
situation.
And here I want to also mention a thing which sometimes I repeat in meetings. So just to remind people, sometimes this is not the only pathology. Once the lens is removed, we have primary open angle glaucoma underlying, which we don't notice. And the pressure may be good because of the phaco for some time, but may go up again. Also, sometimes they have pseudoexfoliation, which not significant. It's very mild and not observed pre-surgery. And the patient may have exfoliation glaucoma later during the following months or years. So I agree that you need to follow them, maybe not you yourself, if there is a reliable place that they can have periodic follow-up, this is enough.
So long follow-up is recommended, so don't discharge your glaucoma patients, guys.
If you allow me, I have a question for Dr. Ibrahim. Would you prefer to go for phaco trap or phaco alone, or do you have a preference, you and Prof. Saleh? If you have equal, which one would you choose?
If they have significant optic nerve damage and they are on multiple medications, let's say this patient on 3 medications, I would go for combined trap phaco rather than ECP. I will.
You don't think phaco will affect your result as for trabeculectomy?
If they are done combined, I think it's better than doing one procedure and another procedure later. So I think this is the best way to approach, and I recommend it.
Prof. Saleh, what is your experience?
Totally, exactly.
Same. You will do combined.
You don't need to ask, one of us.
Okay.
They're friends.
Same. Allah لا يفرق بينكم.
Okay, now this is the diagnostic part. So let's move to the therapeutic part. We'll start with the laser therapy. We have Dr. AlDjasim, a consultant at Glaucoma Division, King Khalid Eye Specialist Hospital. She will teach us how to do good or maybe excellent laser iridotomy or iridoplasty. Please, Dr. Leyla.
Assalamu alaikum. So as everybody recommended, we have to do LPIs. And I think everybody have done LPI before. And so today I'm not going to teach you exactly how to do it, but just a few tips and tricks and what to avoid and what to do. So for doing laser iridotomy, we use either NDIAC laser or argon laser. I've written it very faint argon laser because we don't like it and people have stopped doing it since long time ago. And that's because the NDIAC laser is a disruptive laser. So it makes an explosion at the targeted tissue, tearing up the tissue. So you can open an opening with just 1 or 2 pulses. While in the argon laser, in the thick pigmented irises, you might need up to 100 shots to create an opening because it causes coagulation, burn to the tissue. So you have to burn and burn and burn until you perforate the tissue. And this will create a lot of uveitis that you don't need it. You can use a lens or without a lens. Of course, I prefer if you use a lens, it will be stabilizing for you, for the patient, for the eye. Patient will, blinking will not affect you. And then also you would know where is your patient. When we do laser, we'll be concentrating through the slit lamp. We'll be anxious about the target and the power and everything. So you might notice that your patient is having a vasovagal attack or he just slipping from the chair. So putting the lens there, you would know where the patient is. The spot size is 50 micron, and the power will be between 3 to 5 millijoule per pulse. This is, of course, for the YAG laser, and the pulses will be between 1 to 3. Choosing a pulse is up to you, but usually I prefer if you put it at 1, especially if you are in the training or this is the first eye you are doing for that patient, because sometimes just 1 pulse is enough to open the peripheral iridotomy. So if you do for the right eye, for example, and you needed 2 pulses to open it, then for the other eye, you can directly put it on 2 pulses and then you shoot once. Number of application, it's 1 or up until you will open it. So sometimes some patient will need 1 pulse only, some patient will need up to 5 or 10. The most important thing to do when you are doing laser PI is to pilocarpinize the eye. So put pilocarpine 2-3 times, okay, 5 minutes apart. If he comes to your slit lamp and still his pupil is moving, just put another pilocarpine. Let him wait for 15 minutes. It will make your life easy and the patient life. Here you can see, this is not a pilocarpinized eye, the upper video. See how much the physician is struggling to open the tissue? While here, don't blink or you'll miss it. See, that's it. Just 1 pulse and the laser is open. I will start it again. Okay, because it's pilocarpinized. You can see how the pupil is stretched. And the end result will be either you will see some pigmented tissue, some pigments coming out, or here down, you can see the pigments are floating up. And if you press, you can see the pigments going inside the hole. If you release the pressure on the lens, the pigments will come out. So means there is a communication between the anterior and posterior chamber. The best space to do the PIs are at 3 and 9 o'clock, the most temporal. It's the thinnest. There, the iris is thinnest. You have a big view to see, easier for you to manage, easier for the patient. And it's with less photopic disturbance we will tell you about. Okay, when you want to hit with the YAG laser, you want to hit inside the tissue so that the explosion will happen inside and the tissue will tear very easy. So aim deeper than the surface. So you put the 2 lights, the 2 targets or 4 light targets, depends on your machine. You just concentrate on the surface and then push it a bit until they will be like next to each other, not separated. And this hit will come inside the tissue. Of course, your this is I'm talking if your aim is exactly at the laser target. There are some machines with the posterior, anterior aim, and 0 aim. So I'm talking about 0 aim. Usually, 1 shot is enough, as we've seen with this video. The opening that you target is 200 micron. We said that the target is 50 micron size, so you need just as 4 times as big as your target. So if you did an opening and it was small, it's better to enlarge it radially. It's better to have the best PI is to be a slit so that when the patient is a normal condition, it will be closed. But when the pressure in the posterior chamber will increase, the opening will open. Otherwise, it will not disturb the patient. So if you did a laser and it was small, put another one a little bit temporarily to it. Post-operative complication, IOP spikes, that's why we are giving aproclonidine or alpha-GAN prior, and even after is okay. Uveitis depends on how much disturbance you have done. Many of the patients with 1 or 2 pulses, they will have uveitis for 2-3 days. But if you do a lot of disturbance and you hit like multiple places, multiple shots, maybe you'll need for 2 weeks. And give a good steroid. Don't be cheap and give something not good. Because if uveitis happen, your PI will be closed, especially if you have done a small one, which is preferable. Peripheral anterior synechiae usually happens because of corneal burn and you have a very shallow anterior chamber. So usually, especially, it happens also when you have an acute glaucoma. So when you have an acute angle closure glaucoma, don't hurry take the patient to the laser room. Give him medication to reduce the pressure, give him Diamox, let the patient lie on his back for an hour, and then when the pressure goes down and the eye is less congested, start the pilocarpine and see how it is. So if you don't have a corneal edema, you can do the PI if you have a good access to the iris in the periphery. Otherwise, call him in 2 days, 2-3 days until everything is quietened, and then we'll go the LPI. Visual disturbance usually happen when we have a very bad position, LPI, big LPI, or multiple LPIs. So if we can see here, 1 second. So here, this is a disaster to happen. They are planning to put the LPI here, which will be like mid-periphery. This is a disaster that already happened, where the patient have 4 LPIs in different positions. This is not acceptable. And this happens, as you can see, the patient is mid-dilated, so it happened because he had an acute angle closure glaucoma, and we rushed into doing LPI. We couldn't open once, twice, 3 times, 4 times. And this is the end result. This is what we used to do at the past. We used to put it superior-temporal or superior-nasal. And this is the new approach. Now I'll tell you why. As I told you, the peripheral iris is thinner than the rest of the iris, so it's better put it as peripheral as we can, and the best peripheral that we can see is the temporal periphery. So for the visual disturbance, there are many studies, and this study in 2014, they concluded that the best LPI is to be done at the temporal, is safest, and it has less photophobia. As for the effect of the position, this is older when we used to do it superior temporal, superior nasal. So if you can see, even if a completed cover LPI, there is still 9% will have visual disturbance. And just remember that these patients, because as we discussed the EAGLE study, the older patients, we would do for them phaco and that's it. As for the younger patient, we're still not going to do cataract for them. They are in their 30s. People now are living to 90s and 100s. So you're going to affect them in their vision for a very long time. They're going to be your patient for the next 40 years, complaining of their visual disturbance with the diplopia, with the glare that happens. So even the partially cover is the worst, it's 26% disturbance. The fully exposed superior, still they have 17% visual disturbance. So these are 2 cases with angle closure. The one on the left, they have a convex lens. So this patient, if we'll do for them an LPI, a very small LPI, so whenever the pressure is high in the posterior chamber, what will happen? The LPI will get the pressure to the anterior chamber easily. As for the other one on the right, the figure B, if you do 10 LPIs, he's still gonna close. And that's because his iris insertion is thick. And this is a plateau iris. So what we will do for a plateau iris, either phaco, or if we cannot do phaco or the patient refuse or contraindicated, we can do the laser gonioplasty or peripheral iridoplasty. And here, because we don't want to do opening, we will use a photocoagulation, which is the argon laser, so that it will burn the tissue and you can see how it's contract the tissue. Okay, we have to use a lens. It's up to you, gonio lens or Abraham lens. We have to get the spots at the far periphery as much as we can. Spot size is big, 500 micron. Power is low, 300 microwatt. Duration is long, so that it will burn and contract the tissue without making holes or perforations. And we do 25 spots. Again, the same complications as LPI, but here uveitis is a bit more severe because it's argon laser, coagulative laser, and we are treating a very wide surface. Uveitis might take 2 to 3 weeks, so give them a potent steroid for 2 weeks at least. Peripheral anterior synecia can happen, again, if you do a corneal burn. If no corneal burn, I've never seen a good gonioplasty that causes peripheral anterior synecia. They might rarely they might develop a fixed dilated pupil, no treatment for it. It will disappear within a year or something. This is an anterior segment OCT showing A, before the treatment, B, 1 month after the treatment, and 3 months after the treatment. It's very wide, the angle. And if you are suspecting like there might be an element of convexity in the iris and that might develop acute angle closure, you can do an LPI. Of course, it's after this procedure, the patient will develop a high intraocular pressure. The only procedure that you can do for them is phaco, because once the iris will go back, we remove the lens, the iris will fall back and we'll get rid of the plateau iris. But again, we'll monitor the patient, even if everything is okay, once a year for life. Thank you very much.
Thank you so much, Dr. Leyla. Appreciate the tips and the tricks. Now, if your temporal part is starting to have like significant PS, but the rest of the angle is positionally close, would you still go with the temporal? So
what happens is that the pressure at the back of the iris will increase, and you just need a little bit, a pinpoint puncture that leaks the fluid to the anterior chamber. So you don't know actually which angle is open or working in these patients, okay? But you just need to puncture between the posterior and anterior chamber so that the pressure moves and then moves in the anterior chamber or goes wherever it's functioning. So yes, always temporal.
Thank you so much. Any questions before we move to the, yeah, please, Dr. Ibrahim.
Just personal observation. I have done the laser PI in the superior covered by the iris for how long, I don't know, and never had, patients' complaints. Actually, when I see sometimes patients' location or either the size of the PI, which, sometimes they say, by the way, 50 microns is enough by calculations, mathematical calculations is enough. But sometimes I have this thinking is our population or in our area where you don't have that tear film, you don't have those wide eyes of Caucasians where you have the reflections from the eye, from the tear film and the diplopia. Maybe it's not the same as what is experienced elsewhere. So maybe we need to do or perform our own study here about the location of the PI and see what is the effect of the location about symptoms, diplopia, or sometimes they don't have the diplopia, just they see a light which is disturbing them. So
yeah, exactly. About the light, I have a patient that I did very temporal, and after many years, he told me, I felt a strange thing, noticed after the LPI, that whenever I'm driving in the night on a highway, the car is gone, but still I see a light of it going after it, like an effect. So yeah, definitely what you are saying, but maybe now our patients are getting more like the 50s became the new 30s, and patients are taking care of their like health, better food, better vision. Like for example, the ladies, they are almost more prone to angle closure glaucoma. They didn't have as much as demand for a good vision now because they are driving. They are still working in their 60s in positions with a delicate thing. So yeah, we have to do maybe a study, a questionnaire, okay? But then also before we used to get the patient very late when they have an optic disc damage already. So when we do an LPI, like even for the trap, for example, now many patients, younger patients, they are refusing incisional surgery, refusing the trap because of the lip like morphology or how they look, or they cannot put a contact lens. So generally, the patients are changing, okay? And maybe, we can do a study to find out about the diplopia and then decide what to do for our population.
One question, if you allow me. This is a question regarding, you think that it could be related, the positive dysphotopsias, to the color of the iris? The question is, in Europe, I heard a lot of patients right after cataract surgery that some of them complains about positive dysphotopsias, and also after iridotomies. But all were blue iris, very thin, some of them with a certain degree of transillumination that is seen very often in pseudoexfoliation. Here, nobody complains, but here the iris are thick, dark. Very rarely you see transillumination through an iris, except in very advanced pseudoexfoliation.
Another thing is a question about if there is a PI that you want to close or it is disturbed, what can you do?
Yeah, nothing surgical. So that's why you have to be very delicate. Do a small PI and then challenge it, and if it's still close, you can improve it better than doing a big one.
Do you have experience with using argon laser just at the apex of the PI to
No.
To pull and shrink the iris?
No. I think argon laser maybe,
but make sure that you don't make it larger. I mean, not on the sides, just like peripheral and central to the PI. Can sometimes stretch the PI, make it like a slit, and but you have to be careful.
Sulaiman, you have a question? Yeah, please.
Thank you, Dr. Leyla, for this great presentation. I want to ask about your experience, since you recommended the 3 and 9 o'clock, which theoretically are the areas where the ciliary nerve enter the iris. Do you have experience if your patient having more pain during using or application of the PI, or it is as regular as the other locations? Because they have been describing that 3 and 9 o'clock are usually more painful during Yaga iridotomy.
No, actually no, because usually 1 or 2 spots, and I use a thin area. It's not exactly 9 o'clock, a little bit. Still, I'm like drawn to the superior temporal, but like it's maybe 9.5. Okay, and they usually jump from the noise of the machine, the click of the machine. Okay, but from pain, they are usually complaining of the lens position, but not a laser pain. Yeah, never felt it. Yeah.
Just one last comment, or just a trick for the junior trainees regarding the iridoplasty. We used to learn this during our residency training. You always remember when you do iridoplasty the 3L, okay? L, L, L. These are the parameters of the iridoplasty. L, long duration, low power, and large spot size, okay? So you know your parameters all the time. Now moving to the surgical part,
I'm wondering, how does phaco help, since the pathology is regarding the iris insertion? How does phaco help open up the...
all of our patients, when we do phaco, their iris tend to move back.
But even the iris insertion part, it goes back.
Not the insertion, but the angle will open. Because here you have a narrow angle, and so when you open it, even if you have a thick iris, still it wouldn't close.
So, for example, if you have a patient with plateau iris and he has a visually significant cataract, would you elect to do phaco before doing iridoplasty?
Yeah, phaco, definitely. Phaco, sometimes we are taking it lightly. It's very important to discuss it with the patient. What his vision he wants, what's his what he suspects out of the surgery. Because remember, for a glaucoma patient, multifocal should be contraindicated, because you don't know, maybe at the end they will have just a central vision, and the quality of their vision will be poor in the future. So in a younger patient, even in the 50s, maybe they still wants to use their own accommodation. They don't want to go into reading glasses, especially now all our life is on the screen. Yes, we're all doing the close work. So you have to discuss it with the patient. If the patient wants, if there's significant cataract and he's older, I'll discuss with him phaco is better, because phaco is like a curative for angle closure, for plateau iris, while LPI, iridoplasty, is just a temporary prophylactic measure.
Thank you.
So just move to one of the most difficult and important subjects. It's not uncommon, but usually when I see it in my clinic, I refer to Dr. Konrad. So he's going to speak to us about the nanophthalmic management from the glaucoma point of view. You will mention the KCASH guidelines or tips.
I will try, at least my personal.
Okay.
Because
Please.
I don't think that there is, thank you, Dr. Awood, I don't think that there is really guidelines on this when you start reviewing. And this is a relation of hate and love between the nanophthalmic and myself. I didn't have any interest for it. I was expecting that my colleagues from comprehensive back there were able to do the surgery, but suddenly I was receiving these cases and I have to solve it in one way. First of all, Dr. Jose Belda was the one to be here today, but he has a personal issue that make him impossible to join us. He asked me to extend his apologies for any inconvenience to the institution that he might cause. And in 48 hours, with a brilliant team, the glaucoma division, we were able to assume the challenge and make this seminar for all of you regarding the close angle. So, nanophthalmic, there is no consensus. You can read anywhere about nanophthalmics, and the most accepted axial length is 2 standard deviations from the axial length that corresponds to the age. But all publications goes from 21 less, and you can find 14, 15. Important things related with the pathology is the posterior scleral wall usually is thicker than 1.7 millimeters. Corneal diameter is less than 11. Anterior chamber structure is very crowded, high hyperopia, and the ratio between the lens thickness and the high lens ratio makes that everything is complex. This is the key point from the glaucoma point of view that makes the pathology. Definition or classification is difficult, but what it says is nanophthalmic belongs to the simple microphthalmia, in which the eye morphologically is anatomically normal, and is the difference with complex microphthalmia, in which is associated with syndromatic or with pluripathological. And the embryology issue is related to an arrest of the optic vesicular formation. So basically, we have in the reviews that the classification is around the simple microphthalmia, where there is a short lens, there is the small anterior and posterior segment with a very thick walls, and this is the more or less accepted classification. I have to also thank Dr. Asa Maktabi that ran from his lab 1 hour ago to bring me this beautiful histopathological picture. This is the first time I'm seeing it too, eh? But you can see how crowded everything is in here. It's a microphthalmia, cornea, fibrosis, a shallow anterior chamber. Look, the cataractous lens that is all there and almost no space. Basically, the incidence of nanophthalmic, this is in Europe, is 1.8%. And when we review the genetics of the nanophthalmics, there are many genes, and there are experts here related with the genetics, but many genes are involved. Most of these genes affect the development, the right growing of the eye. Characteristic, anterior segment, everything is small. And this is important for surgical point of view, but also for the IOL calculation. When you have a myopic eye, the effective left position of the intraocular lens, it doesn't matter that much. It can be displaced posterior or superior. It will not affect the refraction that much. But in a short eye, if you displace the lens up and down, as Ibrahim was mentioning regarding to any procedure that you do, it has a terrible optical consequences. And we have to keep that in mind. We are not only trying to correct a glaucoma in a case of nanophthalmic that we do a cataract surgery, but we're also trying to improve the quality of life of these patients. So take into consideration anterior chamber here. We can go from a range of 1 millimeter to 2.7 millimeter with an average of 1.46. This has an important relevance because our faculty has 2.1 millimeters. So if we have 1 millimeter, we have a tip inside of the eye that is double the space we have. This is a surgical concern. What about the posterior finding? Well, this is one of my patients here. You have a very crowded optic disc. Which cupping is this? It's difficult to evaluate a cupping in this. You can imagine that you have in a very small space 100 nerve fiber layers, and in the same wide space, like in a myopic optic disc, 100. So everything is expanded. Here, everything is compressed. You also have folds in the macula. A lot of these patients cannot improve the vision just by removing the lens because they have amblyopia per se. Foveal aplasia, also related with the amblyopia, and a yellowish pigmentation if you are able to see that fundus. This is our database. I was interested in see how often is the nanophthalmic, because for me it seems that it was a lot here, more than I was used to see it in Europe. So I requested, and Ibrahim said one thing important. Every time you set a diagnosis in the trachea to order a medication, try to be as more specific as you can. Because out of 773 diagnoses of high hyperopia, I found 42 nanophthalmic eyes inside of that database. And I have the list. This was from 2014 to 2021. Out of these 42, I don't know if I have to say lucky or unlucky to do the surgery in 11 of these patients. 7 were bilateral, 4 was monocular. So a total of 18 eyes since 2018 till date. This is, the calculation you do with a calculator, no statistical things. I just took the data that I had because I wanted to present to you. Axial length was an average of 16. IOL calculation, amazing, an average of 51. This is what you expect. Where do you get a 51 diopter lens? I sent it, I remember the first case, I sent it to a colleague in anterior segment, and he said, there is no lens we can implant in this case. And it ended that a brand in UK is making customized lenses for us. This was the presentation of all the cases. As you can see, the females there were mainly types of glaucoma, chronic, acute, angle closer. But in the male file, there is a lot of angle problems or acute glaucoma problems, but there is also choroidal folds that it was not present in the ladies, corneal decompensations, and the other dense ones is a lot of pseudosfoliation and already uveal effusion syndromes. And this was the outcomes of these cases. Best corrected vision, most of them improve. One get worse, and that one that get worse got blind. Unfortunately, it was a case that she didn't want to have the surgery until it was very, very late. One of the cases has a refractive surprise of -3 diopters, and it was solved when I did a capsulotomy. The lens moved forward, and that refractive surprise improved. One of the cases that was not controlled, was controlled for 1 year with just a cataract removal, at 1 year needs a pole implant. But I will show you the pictures later. The good thing is that we got a space enough to put the pole implant. Remember about the synechias. All synechias in extension or broadness are related to the high level of intraocular pressure in acute angle-closed glaucoma and in chronic angle-closed glaucoma compared with suspect patients. So the paths are very important in the pathogenesis of this kind of high pressure patients, all right, as you can see here. This is another beautiful, beautiful slide from Dr. Asa. You can see the paths the synechias develop when the iris is in contact with the cornea. And this doesn't happen quick. This sometimes needs times to be exposed. And this is a beautiful paper in which 7 years just of simple contact between iris and cornea, in 7 years develop synechias. So we know, at least from that study in population that is Asia, I don't see many Asian people here, but anyways, we have to think that the longer the contact, more chances of developing pus affect the trabecular function, and probably just by removing the lens, it will not do anything. This is applicable to chronic angle-closed glaucoma, but remember that nanophthalmos is the stream situation of a closed angle-closed glaucoma. Eagle told us about, Ibrahim presented very good. So how do we approach these stream cases? First, you use friends. You ask them if they want to do the surgery. In this case, Dr. Sesma, but not very oftenly he is willing to do it. Second, request comprehensive. They are always willing to do nanophthalmic eyes. Dr. Naif, I see him there. But if they say no, anterior segment is another option. And at the end, very oftenly, these patients ended in the hands of the glaucoma hands. Why? And that's why Dr. Wood laughed, because I said the best anterior segment surgeons, and sorry, Dr. Rafa, are the glaucoma guys, because we deal with these things. So what I will, these are jokes, by the way, they are all great surgeons. Eh? So anyways, how you approach these extreme cases. One of the things I learned here is the most important thing is a very accurate history taken. Why? If a patient lost an eye, one of the cases I deal with, he has effusion choroidals in the other eye after a cataract surgery. So these are the ones you really have to send. But if you cannot, you really have to face it with precautions. When was the setting of glaucoma? Since when he's using the medication? How long stand this procedure? The longer, the worse. That's why, and this was, I wanted to answer that question that you did. I will go for cataract surgery or remove lens extraction even if they are young, because what I have seen here in this extreme situation, at least, the earlier the better. This is my impression. Physical examination, very important. Not only avoid, of course, pupillary dilation. I don't think that is needed here because you can have a problem, a big, big problem, and then cold eye goes into a very hot eye into the OR. So the best is the calmest that you can handle. But it's important to explain all the prognostic to these patients. They have to know what are our goals to do it. Regarding DID test, B-scan is very important. We will talk a little bit about that. Ultrasound, biomicroscopy, OCTs, endothelial cell count. The IOL calculation, I will have a mention on this. But the effective lens position is the most important part here if we want to get the best quality of life of these patients. If you remember the previous table on my results, most of them has plus 14 diopters of hyperopia. A lot of them went down to 1 to 2 diopters, which is quite good. Most of them were very happy. The first one cried in the clinic the day after, and I was like shocked. I said something is going wrong. And she said to my assistant, I think it was one of my fellow, and I said, what happened? I don't know, it was Dania. Dania, I think it was you, because in the case we present. And you told me, she said that she never has seen like she's seeing today. So that was shocking. Very important, mannitol. Don't take these patients to the OR without mannitol. You too that you like the risk, eh? I can see you at the back. I will recommend the 24 hours before and 1 to 3 hours before the surgery. Regarding this, you can, I mean, when you see these outcomes, you can imagine, I will never open an eye if it's not extremely necessary, even if it's a small cataract incision surgery. I would rather prefer to go to phaco. And I think the phaco and the extracapsular make here the totally shift of the paradigm. Extracapsular in these eyes were terrible, but phaco, well handling, seems that it's doing better. But one important thing, pus is also related always with the glaucoma. So we have to try to avoid that pus develop. This was the case that we were able to present, one of the first we did here. And this is the lady. And she was, the spherical equivalent went down to -1. One eye is still under control just with the phaco. The other eye had a pole implant. It's doing well too. But look how was the anterior chamber. And you can see all the pus. These are the gonioscopic view that you can see there, 360 degrees, more or less. Both eyes looks quite similar. And you can see the posterior pole of that patient. The folds that were expected. And this is the surgery. It was a clear lens extraction. What are the advantages? Basically, no ultrasound needed. You can see that there is almost no room. So, and I had Dr. Semidey by my back, by the way. He was there because I requested just in case of need. And I know retina people doesn't like to do pars plana vitrectomy here because they don't know where the pars plana is. It's so short that sometimes the room is not enough. 52 diopters lens, eh? This was the angle before, and this was the angle after, with the 52 diopters lens there. We were able to present that video at the American Academy because I think was the first time a 52 lens was implanted. So when we talk about this, and we have the fusional choroidal, all of you, especially the ones that have been here in the game, knows that we should do a sclerostomy because that reduces the risk of a lot of complications. But a sclerotomy has a risk itself. And here comes again, maybe, this is the reasons why the uveal effusion happens. All those genes that I showed you before affect the development of the proteins of the sclera, making it worse in stiffness, in rigidity, and in thickness. And that makes that the blood vessels cannot drainage properly. So that's why we relax the sclera. And this was the main 3 techniques to do it. But you can imagine how to get back there, only probably retina and pediatrics that go back there to play with the muscles. The idea was to try to make a dissection around the vortex veins, but this is very tough. And the risk of breaking the blood vessels is very high. So my preferred technique is the Anderson one. But in everyone, in some. Well, I think that the most important parameters here to have in mind, if there is a sign of liquid in the interface in the B-scan, if there is the patient has a previous uveoscleral syndrome in the other eye, if the sclera is over 1.7 millimeters, and probably I have to add in case of doubt. This is another nanophthalmic eye, and you will see the difference here. White cataract. I hate white cataracts in a nanophthalmic eye. But the good thing here, and I understand that, for example, anterior segment refers to us, we do flap like walking or eating. This is our daylight, tubes and flaps. We can do it with the closed eyes, mainly. The important thing, you can put, I leave it without closing the sclerotomies, has to be deep, deep, because the idea is to relax that tension. I don't put mitomycin there because I really want in the immediate time. And so far, since 2018 till now, it works well. So I will not change so far that part of my technique. What about capsular tension rings? They have tendency to fluctuate, to have a sonular weakness. In case of doubt, again, put a capsular tension ring. But we always consider we have a small space there. Everybody's crowded in that room, and you can hardly move. But if you are in any step of the surgery and you feel, I don't know if you notice the movement of the lens, and it's a little bit dislocated. As soon as you have room, put the capsular tension ring, slowly, everything, let the ring to expand around. Vitrectomy. Dr. Rubio is not here. Basically, this is what they do, we don't do. This is the only thing I think glaucoma we don't do, right? We prefer to have the retina guys around. But basically, the point of the vitrectomy in this case is if we have, and these are my indications, high pressure, small anterior chamber, you know that you can put all viscoelastic you want, it will never go down. It will remain a small room, the viscoelastic will come out. If you have low endothelial cell count, you don't want to have the tip of the probe close to the endothelium. If there is a high-risk patient for misdirection syndrome, again, in case of doubt, call the retina guys. There are many papers regarding this that says the benefits of doing in combination, lowering the pressure. There is this amazingly long number, and nobody's going to remember this technique. But anyways, basically they did everything. Everything that you can do, the Chinese did. And they got about 88.9% of success regarding the IOP control. We thought we were having the biggest lens 52, but the Germans did it before us, and they published even before us. So for all of you, this is an amazing open access book on IOL calculation. Everyone that deals with cataract, intraocular lens, glaucoma, or whatever, should have access to this book. You can find it on the internet, very easy. Aramberri is a guy, Spanish guy, that works on IOL calculation for many years, and this is the last thing that it came out. And this is the way, by the way, before reading this was the way I was using. I was taking all the IOL calculation formula and making an average, and this is the way I calculate the IOLs that I use. But they suggest to use the latest formulas, at least 3 of them, make an average, and that is the power. My last slide on surgical tip. Surgery is very difficult, so get into it when you feel confidence on doing this kind of surgery. Try to work everything through paracentesis. Keep the eye stable. Viscoelastic, try to avoid the fluctuations inside because that is what it causes the misdirection syndrome. If you feel that the tip pro is going to be too close to the endothelium, central pars-plana vitrectomy is better. Capsular tension ring in case of instability. Capsulorhexis, I prefer to do a capsulorhexis wide enough so I will have everything coming easily without many maneuvers inside of the eye. Better to close the incisions. Sudden increase of pressure or fluctuation of the pressure related to the high of the bottle can cause choroidal effusions and choroidal hemorrhage. So keep everything stable and monitor, always monitor. Thank you.
Thank you so much, Dr. Schargel. This is very intriguing presentation and subject, and I believe this presentation should be a reference for nanophthalmos, at least for us here at KCASH. Few questions. I'm sorry we are going beyond the time, but I think we still have more time. There are no other activities for now. Now, you said that with those high power IOLs, there is a customized IOL that you can order. Now, if you don't have that option available, would you go for biggie bag lenses? Yeah, I know it's an old fashioned.
No, but I had
yeah.
the idea that you were going to ask me something
Okay.
like that. No, piggyback is an option. We stopped using it because the terrible interface that grows in between the lens.
Okay.
And there is no way you can clean it. There is no laser, it can be used there. That's why we abandoned the piggyback. But in theory, it can be used. There are, in that book that I showed, there are some ways that they recommend. I haven't used it lately because I have the customized. But the recommendation I found in the book is, for example, the largest diopter lens implanted in the back. The other one may be better, a 3 pieces lens in the sulcus, less power. And usually they recommend it, if there is the chance, use the highest power first, and in a second surgery, implant the second one, corrected according to the refractive residual defect that was remnant.
Okay.
This is the way they recommend it. I haven't used, I hope the guys from Comprehensive can give us a hint when they have to do it the first time.
Would you put them both in the bag if there is a bag?
The both IOLs?
Yes.
It's a tough question. Honestly, I don't have an answer for that today. I probably will have...
Dr. Rafa?
I think the ones I'm experienced with is one in the sulcus, one in the bag. I doubt that the non-ophthalmic eyes would have enough space in their bag to begin with. One of the most important things to worry about or to counsel the patient is the development of membranes in between. So you need to consider what type of IOLs and are they compatible with each other or not.
Yeah. Thank you.
Thank you very much. This is a very challenging topic.
Thank you.
And really, but I have two comments. Regarding the sclerostomies or sclerotomies, there is a study in a different pathology, which is the stage over syndrome. It's published in, I don't remember, I came across that long time ago in American Academy of Ophthalmology Journal or so. They compared with or without, they found no differences in the outcome, whether you do it or you don't do it.
In a Schargel.
Yeah, but
yes,
a different pathology, but probably the virus was the same, of choroidal fusion and these things, probably the same, although the topics are different.
Yeah.
There's one thing. Yes, you will say that non-ophthalmos, thick sclera, different from that pathology, although it is the thick sclera also there. Anyhow, the other thing is regarding you said that the vitrectomy should be done by retina. Okay. Yes, I agree with you. But we are glaucoma people dealing with such a thing. I remember we trained by big people long time ago. I wouldn't say how many decades, but yeah. But in thecomorphic glaucoma, always there is a shadow chamber, very shadow chamber, and as you mentioned, whatever amount you put viscoelastic wouldn't change the chamber depth for capsulotomy. At that time, it's not phaco. So our mentors at that time, they advised us. Of course, you have done the scan and everything that you ruled that the posterior segment is okay with the normal. So you can go with just MVR blade. You know the anatomy of the eye, where you to go, which direction you're gonna take, and then apply the cutter only, no sleeve, no irrigation sleeve, and a few cuts, 4 or 5 cuts. Then you will see the chamber is very deep. You can do whatever you like. So I don't think the retina, with respect to our colleagues in retina, not everything retina, sometimes you don't have retina around you. So yes, the glaucoma people, they should be, and we are privileged in KSU. I have worked here many times. I learned this. I grew here in this institution, big institution. So we learned a lot from our mentors. And so you don't need, you can do it by yourself. Thank you very much.
Thank you, Prof. Sorry,
I'm
Dr.
agree with you,
Nuwaila.
I'm
Sorry
absolutely
to
agree.
Dr. Nuwaila.
I do my own vitrectomies when I have privilege. Here I don't have. I prefer to. I have friends here.
Thank you again, Dr. Konrad, for this excellent presentation. And now I know where to refer my cases.
Yes.
To me, and I send it back there to the comprehensive guy.
I just want to share some, let's say, not so pleasant experience long time ago.
Yeah.
Actually, at the time of the CBC or even cyclocryo, I can't remember very well, but two cases of end-stage glaucoma with nanophthalmia, I did cyclodestruction. I did probably one case is like 3 quadrants, one case is only 2 quadrants, but both went into hypotony.
Oh.
I think those cases we should avoid the cyclodestruction. They are not like normal eyes.
Absolutely.
So it's even if they have end-stage glaucoma, maybe it's better. I don't know about the micropulse and its effect, but try to avoid the cyclodestruction as much as you can.
Yeah. Any specific tips or tricks in your phaco settings?
Well, I think that the most important parameters are at the beginning. It started at the clinic. I don't know to which one of my fellow we were discussing this. There is no real guideline, but if I have a patient with a shallow anterior chamber and high pressure that is not responding to medication, as I said, there is no way it's going to be retropulsion. And I remember what you say. There is Chandler maneuver that is just putting the 30 gauge needle and aspirated. It could also work in some cases. So for these patients, I try to set the bottle low, pressure like in 40 millimeters of mercury, and I try to have a large vacuum if it's a cataract, if it's lens aspiration, parameters for lens aspiration only. And in such a case, I just go for the paracentesis, not even phaco tip. I only open the center just to introduce the lens. That's why I like clear lens, early stage. But if it's cataract like the one white one that was there, aspiration in around 30 millimeters, so it can attract the fragments. Power depending on the hardness of the cataract, but around 30 to 40 percent phaco power should be go fast, but you have to adjust according to each one of the cases.
Okay. And my last question, at one of your tables, you showed the mean height and weight of those patients that you had here at KCASH. Is there any relationship of that?
No, but I found that a lot of the patients are usually short and chubby.
Okay.
And complex microphthalmia is, no, you are not either one, but complex microphthalmia is related to some syndromatic conditions. And that's why I was looking at those that are there in the file, by the way.
Yeah, okay. Thank you again,
Thank
Dr.
you.
Schargel. Appreciate. Okay, now last but not least, we have Dr. Sulaiman Tariqi. He's a second-year glaucoma fellow at King Khalida Specialist Hospital. He will share with us his video that has been awarded as best video in glaucoma or for glaucoma in the Red Sea SOS last 2 weeks back. So first, congratulations, Sulaiman. It will be about PreserFlo in secondary glaucoma. Enjoy.
Assalamu alaikum rahmatullah. Thank you, Dr. Ahoud. And it's my pleasure to share with you our surgical video of PreserFlo microshunt implantation in secondary open-angle glaucoma following scleral buccal retina surgery. Actually, before presenting the video, I would like to touch on a few minutes on the latest data on PreserFlo, because it's always when it comes to PreserFlo, we have those who are conservative and those who are very enthusiastic. And to really have a good comparison, we always have to compare it with our gold standard. Although it will be irritating for those who are very conservative, that we are going to compare PreserFlo with trabeculectomy, but we will show the latest data available, and we will criticize the data. So for those who are not very familiar with the PreserFlo from other specialty, as we know, it is made of SIPS material, which is biocompatible material. First used in human body was in the coronary arteries stents. It has 8.5 millimeter length with two parts and central wing-like structure, which lies in a scleral bucket. The 3 millimeter distal end lies under the conjunctiva after the wing, and the other part, which is around 4.5 millimeter, is embedded within the sclera, and part of it will be in the anterior chamber. And since the first use of PreserFlo in 2015, the number of publications has been increasing. Until now, in 2024, the number of publications in regards to PreserFlo are reaching 67. So when we compare PreserFlo, I went through one of the recent largest meta-analysis that compared PreserFlo with our standard gold standard therapy, which is a trabeculectomy. And another interesting review that came recently from the United Kingdom, which compared both intervention in terms of cost effectiveness. So when it was compared in this meta-analysis in terms of effectiveness, IOP reduction and the number of medication, it was all on the side of trabeculectomy, where in trabeculectomy you can get IOPs in single digit, unlike the PreserFlo, where the IOP usually, if it is successful, stabilized at the mid to lower teens, and of course the number of medications were significantly lower in the trabeculectomy groups. In terms of safety, it is really surprising for some of us that it is it was publicized that PreserFlo has a very good safety profile, and this is true if you go through each article separately and read it, because most of the article are having low number of patients. But in this meta-analysis, when we gathered all the number of patients and all the participants in the sum of these articles, and we merge it in the appropriate statistical analysis, it has been shown that the PreserFlo and trabeculectomy have the same safety profile in terms of hypotony, choroidal effusion and detachment, hyphema, flat anterior chamber, except that for bleb-related complication, it was higher in the trabeculectomy group, as well as the reintervention rate was higher in the trabeculectomy group, and the follow-up visits were more in the trabeculectomy group. So the message from the safety profile is that as PreserFlo is not as safe as we believe or as we get from single article publication. In terms of cost effectiveness, it's really surprising for us that the only study that's available in the literature, which came out recently from UK, it showed that PreserFlo, when you compare it to a trabeculectomy, although the implant price is higher, actually in the market now in Saudi Arabia, it costs 6,000 riyal. This is for the implant itself. But when we compare the whole journey since implanting the implant and the follow-up visit and the need for reoperation for both trabeculectomy and PreserFlo, the PreserFlo group usually for single eye it costs around 4,000 pounds, and for the trabeculectomy it cost around 4,216 pounds. So PreserFlo microshunt was in this study more cost effective than trabeculectomy when we calculated the operation itself as well as the follow-ups along with the need for reoperation. Of course, such finding need to be studied more in our population because the number of follow-ups and the costs that we are having here are different indeed than the one in the country that was studied. So this is the meta-analysis that I was referring to in term of safety and effectiveness. And this is the study that mentioned the cost effectiveness comparison between both interventions. So before we present the video, for those who are really conservative in terms of the use of PreserFlo, well, we need to be more open-minded and think that it has some effect, but not as a replacement of trabeculectomy. And for those who are very enthusiastic, it will never replace trabeculectomy. And as a reminder for all of us is, despite the advances that we have nowadays, we still have to continue to figure out a better option for management of glaucoma, options which have less cost and better efficacy and higher safety profile. So we elected to use PreserFlo in such case because the current techniques that involves managing glaucoma in patients with scleral buckle and in eyes which carry higher risk for complication, especially in myopic eyes vitrectomized with scleral buckle, requires either going around the buckle itself or the band and placing the plate or fixing the plate to the buckle and the band, which carries a higher risk of dislodgement of the buckle or the band, and hence increasing the risk of the recurrence of the retinal detachment, or doing the traditional surgery, which is trabeculectomy and increasing the risk for the complications such as the hypotony, as these patients are very high myope and vitrectomized. So at first we did the good size periotomy, and we went with the dissection above the buckle. As we know that since we started using PreserFlo, the first technique that we were using it is by doing a periotomy similar of that we do for deep sclerectomy and trabeculectomy. But with the experience that we gained, nowadays we are performing it with a large periotomy similar to the periotomy that we do for tubes. And the concentration of mitomycin C is larger. Now we're creating the tunnel as usual for this implant around 3 millimeter from the limbus into the anterior chamber. After that, placing the implant into the anterior chamber and ensuring the flow is consistent. Then what has changed since we start using the implant is now it's recommended to fix the implant into the sclera. This is one thing after doing the large periotomy and the high concentration mitomycin C. The other thing that is recommended is to close the conjunctiva in 2-layer closure. So we close the tenon and then we close the conjunctiva, because it's not uncommon to have the tenon entangled within the tube. So this is a 2-layer closure starting with the tenon. So after closing the tenon, now we're going to close the conjunctiva. So by this we conclude this presentation. Thank you so much for your listening, and if you have any comments, we'll be happy to discuss it with you.
Thank you so much, Dr. Sulaiman, and I was glad to be the supervisor for that video, and you should share the award with me. You should pay me the half for that. So, yeah, as Dr. Please, Professor, go ahead.
Very nice. Thank you very much, Dr. Sulaiman. Like you don't put a suture on the PreserFlo to minimize the possibility of erosions.
Well, this has
been recommended by many people.
Yes, when first we started using the PreserFlo, the company recommendation was not to put the suture. Along the time, the recommendation came that it was better to place a suture. So nowadays we are fixing the implant with the suture to the sclera. And one of the techniques that is recommended now to be done, especially in such cases with a higher risk, is to place a ripcord, nylon ripcord to the lumen, to minimize the risk of postoperative complication.
I think we're still in the phase of like training and try to explore and discover the implant. And we are seeing more of cases that we need to be revised actually. And as a follow-up for that case has to be revised, but the patient is doing very, very well right now.
It was implanted in May 2024.
Yeah.
And
it's like just 6 months, around 6 months, yeah.
And one thing that I want to highlight here that it was not mentioned in most of the studies, which is the quality of life when comparing trabeculectomy to such implants. It's something worth studying, especially in patient who doesn't need a single-digit target IOP. Is it an option for them to use a PreserFlo in selected cases, of course?
Yeah. But I think it's a good tool, good implant to be used even with secondary glaucomas. Like, as you can see in that case, we could easily proceed putting it with the scleral buckle. We did also cases for patients who had already previous failed traps and DS, and it was easy to implant. But of course, for each case, you have to be very selective and you have to use tips and tricks for each case. Like you have to go very posterior with the dissection of the conch. You have to put high concentration of mitomycin. And it's very important that you close 2 layers. You don't leave the tenon redundant and you think that you closed everything. Just go ahead and do it level by level or layer by layer. Close the tenon and then again close the conjunctiva. And my 4th tip is to put the patient on long-term steroid, topical steroid. I usually go with 6 months, okay? I keep the patient on PRIT40 for 6 months, especially for those cases which are secondary glaucoma cases, very important. You keep the patient on long-term steroid. Any comments or questions? Okay, I think we have to conclude. We thought it should take or it was, scheduled for 1 hour, but we took 2 hours. And I'm so glad to see you all here staying till that time. Thank you all. Thanks for the amazing team for taking care of this in a matter of 2 days. Thanks for all the guests. Thanks, Prof. Al-Abadan. Thank you, everyone, and enjoy the rest of the day.